Welcome to another conversation in wellness. I'm so happy that you're here, and I'm so happy that my really good friend, Dr. Mario Evon Guthrie, has decided to join us this morning, whenever you're watching. Yay, Dr. Guthrie, thanks for being here.
Hi, Natalie. It's a pleasure.
Little intimidating as you are a podcaster, and I have zero, other than these conversations in wellness, very little experience interviewing.
You're a personality. So
I'm a personality.
Right.
I'm a color, Mario. Don't forget it. So for those of you who do not know, who live under a little bit of a rock, Mario wears multiple hats. As a medical practitioner, he's Dr. Mario Guthrie, studied at the University of Western East Bona campus, graduated honors obstetrics.
And gynecology, yes.
Wow. Yeah.
And anatomy.
Honors obstetrics and gynecology. That's pretty intense.
And I believe anatomy. So those are my two things. I mean, some people got honors in everything. So I guess, hey.
Honors in anything medicinal, I think, is hats off, right?
All right.
Dr. Guthrie works he has a private practice, and he also is at the Accident and Emergency at the Bustamante Children's Hospital. That's pretty phenomenal. That's one of my favorite places. Yeah. Love to support Bustamante. And then the other hat is that Mario Evon is a singer-songwriter fusing R&B soul with reggae.
Yes, I call it reggae soul.
And it's a lovely, lovely sound.
Maybe
he'll sing for us, I don't know.
He will. When he changes his hats.
And as a podcaster, Mario is available to you on Talk Truth. I didn't do it right. Can you do it?
Talk Truth!
There you go. So Dr. Guthrie and I met many moons ago on the set of CVM at Sunrise, where he was interviewing me. So there goes the motorcycle. Thank you very much.
Wait to see if I have a turn.
Did you hear it driving fast?
I did not hear it actually, which is good.
Okay, good. So we will ignore all outside sounds from this point on. So we're here talking to Mario, Dr. Guthrie, this evening. I'm going to call you Mario. Is that okay?
Call me Mario. That's fine. Yeah.
Perfect. Okay. We're here talking to Mario this evening about know your numbers. So, on Conversations in Wellness, we want to talk to all sorts of different practitioners in all sorts of aspects of health and wellness. And today being in the month of November, which is Diabetes Awareness Month, we thought it prudent to talk to you about your numbers. So, Mario, jump in for me. What are the numbers that we need to be talking about?
Well, there are tons of numbers, but I guess a good way for me to start is, as a general practitioner, what I like to do for all of my patients is give them a roadmap per se, or some kind of guide or something that they can reference to know where they are in relation to it. And that's kind of what I mean. We have a lot of studies that have decided what are normal blood pressures, what are normal blood sugars, what is a normal weight for a particular height. And these are some of the things that we as traditional health practitioners look at. And when someone comes in, I do their height, I do their weight, I calculate their body mass index, we'll get into what these are, so that they know where they are, because there is some medical significance to these numbers.
That's what I was going to ask you. Like, who decided what are the norms and what's the purpose?
Well, truthfully, like everything in medicine, there are a lot of studies. And what a study is, for people who don't know, is that pretty much you put together a group of people, usually different ages, races, and you do tests on them for a long period of time. And medicine has been around for a while. So we've been following up on blood pressure and sugar and stuff over the while. So what you'll find is, in different countries, you have different organizations that set the guidelines. And the guidelines do vary from country to country too, but they do tend to be close. So a lot of the guidelines that I am going to reference today, some of them are American Heart Association. I somehow decided to use American guidelines, but again, they are guidelines and they are based on clinical studies.
Do we in Jamaica have such guidelines that are specific to our population, or do we rely on the American guidelines?
You know, I would say informally we do. And I wouldn't say that we necessarily have Jamaican guidelines, but I also can definitely say that in a lot of the postgraduate programs, there are people who research and do studies that do look at our population because it's such a very specific population,
right,
in terms of racial and also other stuff like body mass index, the kind of foods we eat.
right.
So it is important for our country to kind of look specifically at our space because our space is different from their space.
Yeah, and everybody's body is different. So if
And
you're looking
everybody's body is different, right?
if you're looking at our cohort of Jamaicans, it's very different from a cohort of Americans. So.
And we're eating yam and banana and all sorts of stuff. Now we're in a warm weather climate.
Plantain? Do we eat plantain?
Do we eat plantain like a one-handed bandit plantain? Anyway, who knows anything about plantains? Manu.
Who knows anything about plantain? So screening tests then. What is a screening test? We're testing against standardized norms. That's what you're saying.
Well, a screening test actually is a test done in someone who has no symptoms.
Okay.
And the aim of the screening test is to pick up the potential for disease. So that's important. So the person has no symptoms, they're asymptomatic. So we are trying to actually pick up anything that could clue you in to the development of a disease. And a perfect example of a screening test in women is the pap smear, the mammogram, and prostate-specific antigen, that's the PSA done from the blood to look at your prostate. And of course, the pap smear would be for cervical cancer, the mammogram would be for breast cancer, and the PSA would be for prostate cancers. We have to break this stuff down.
Okay, so I just need to play a little bit of a gender card. How come you guys get a blood test and we have to do squeeze up breasts and invasive for ours? Are there no blood tests that can test for the cancers that are specific to women?
That's a great question. I mean, well, there's the digital rectal exam as a part of the prostate. So here's a little invasion for the men. And you know, we Jamaican men don't love it. But you know, there's a CA125, which sometimes we do for ovarian cancer, but it's not necessarily a standardized screening test. It's just that with ovarian cancer, when it becomes present, the CA125 increases or may increase. So it may clue you in, but I think at the point where you pick up a high CA125, you may actually have disease.
Oh, you're too far
along. It's functioning as a screening test.
Gotcha.
And medically, there are some other things we want screening tests to do. We want them to be sensitive, specific, and affordable. So,
yes.
So you know, when people are talking about testing people for COVID before vaccination, it's not so practical because a lot of people don't necessarily get sick.
Yes.
Even if they're vaccinated with COVID, even though it's not recommended. So the outcome of doing that and the cost of it, they don't really align well for a practical screening.
Yeah, because cost would definitely be a deterring factor for screening.
It would, and then I figure that most people actually would be well, actually, even though it's not recommended. The outcome may be that they're fine. So
yeah, go ahead. Sorry, I had a question coming up.
It wouldn't be a practical screen test, whereas a pap smear now is cheaper to do. It's relatively affordable. I mean, there's some cytopathologists, that's the person who looks at the smear on the slide. Some of them charge as little as $1,000 to process a slide, you know?
Okay.
So, you know, some women can do a pap smear for as cheap as $2,500 to maybe more in some spaces, but it's still on the cheaper end.
Yeah, and considering the long run repercussions of what you could be catching, you definitely want to catch these things early because these screening tests, whereas not preventative, they can allow you to catch things early enough.
That's exactly the point of it, right? So they're not preventative, and usually they lead to further investigation. So a good example is an abnormal pap smear will pick up something that would be a clue in, but then the next step would be either repeat the pap smear in 6 months or go to a gynecologist and do what they call a colposcopy, where they magnify that cervix through an instrument, and they can actually see up close what might be going on. They might burn, they might cut off something, but that's curative now.
Right.
And if it's further along, then you probably have to do a hysterectomy at the other. But and same thing with a mammogram, it would pick up potentially a lump. But once you find a lump, then you have to biopsy the lump to find out if it's benign or malignant.
Right.
So it's just a clue in so that we can jump in early and intervene. And for most of our medical stuff, that's what we want.
So with all of these screening tests for so many different things, how do you know what you need to be screening for?
All right, great question. And well, as you know, there are a lot of lifestyle illnesses which affect most people all across the world, right? And particularly in our population, Jamaica, hypertension, diabetes. So now we're just looking at what is common in the population as well. And we know that there are things that link to these diseases like obesity. And also how you eat, even though how you eat is not necessarily causing the disease per se, but it affects how you regulate the disease. So that's kind of how we decide. And some of the stuff, as we say, are things that are common. Diabetes, hypertension, and the cancers that are common too that kill people. Breast, cervical, prostate, colon. These are common across the world. And especially now, based on our diet as well, a lot more oily food, a lot more fast food as well.
Yep, so, causing inflammation, causing disease. True.
Yeah, exactly.
So based on the things that occur commonly in our area, we're going to look at certain screening tests, and then we look a little bit about a genetic predisposition based on heredity.
I love that you're leading me here. I always tell you should have done medicine. I thought you said you were a bad interviewer. You're excellent. Of course. And when you look at the different guidelines, interestingly, a lot of the screening guidelines start around 40. Was that a cat? 40, 45, 50, which is kind of interesting. But I think it comes right back down to where the person at moderate risk would most commonly develop cancer. So that's why those ages are kind of there. But when you look at high-risk people now, we're looking at people with first-degree relatives. And by a first-degree relative, I mean a mother, a father, a sibling, a blood sibling, right? And we're talking blood parents who have had cancer in general or even at a young age. And this will cause your screening tests to shift down.
Okay, so this is interesting. Does it matter the type of cancer? So like, you know, my daddy had prostate cancer. I obviously do not have a prostate. But does that mean my cancer screening should shift down?
No, not based on the guidelines.
Okay.
But, and I'd probably really need to check the research on this, because I do believe that there are some families that do have a propensity for cancers in general. So even though it's not one that you can potentially have,
right?
You have like families that have cancers on both sides, and I do think it's something to clue into as a physician.
To say.
But to be more specific, and let's use prostate as an example. If you're at moderate risk, you start at 50, age 50. If you have one first-degree relative, so that's your father or your brother, and they say they had it when they were less than 65, so that's what they're using, less than 65, because most times it happens in older men. Then you shift that down to 45 to screen.
Okay.
If you have two, say if it's your father and your brother under 65 and both of them are diagnosed with cancer, then we're shifting down to 40. And this is the American criteria. So you can see how having a first-degree relative shifts your age. And the same thing with cancer. You have some women who in their family, like, they'll tell you their sister had it at 35, you had an auntie who had it at 40. Like those are young ages.
Those are very young ages. Yeah.
And if you are in that family line, you have to screen early. And normally you would be doing a mammogram like at 45. But in that situation, you shift down. And for women who are younger than 45 who do develop breast lumps, they would tend to go with a breast ultrasound, because mammograms are actually x-rays. So the breast ultrasound is what they would do in younger women based on age and also the density of the breast tissue. And in some cases, if they're not picking up what they want with the ultrasound, you may have to do both. Sometimes you do a mammogram and they'll be like, no, not clear. Let's do the ultrasound.
Right.
They combine the two and see how the two work together.
Right. So in making the decisions about what tests you need to do, this is really something like, just going to walk into a place and say, I would like to do a test. Like you've already gone to your doctor. You guys have discussed your history, your family, your whatever. And then the doctor is going to decide, you guys, as if I'm in consultation.
I know, right?
The doctor will decide what screening tests you need. So this is done during your annual medical that you normally go to the doctor and do that. Not everybody does.
Right. Well, let me tell you, it's 2021 and people do walk in and request things that they want.
Okay.
And in a world that we're in now, if it's not unsafe and people are willing to pay to check themselves out, I don't think most doctors will refuse.
Okay.
But we are also here to guide. Like if somebody comes in and says, I've had a few headaches this month, and it's mild and it's not getting worse, and they don't
I'd like an MRI, please.
I want an MRI. Then I'm not the doctor to come to, because if you tell me you want a CT scan, I'm going to tell you no. I'm going to tell you let's treat the pain. I'm going to tell you let's watch it, because again, radiation.
Right.
Like I'm not exposing you to 5 CT scans for your lifetime if I don't have to. That's me.
Right.
Because that has its own implications as well.
Absolutely. Some bodies are just particularly sensitive to radiation, and some bodies store the effects.
There's evidence that if you have had many CTs, it can potentially sometimes lead to other things. So,
right.
So you have to be safe. So back to your question, yes, once you hit a certain age, especially if you have risk factors, which could be weight, age, family history, start to screen. And people are going to ask what that age is. Based on most of the guidelines, it really does lean up into like 40, 45, 50, to be honest.
Okay.
But that changes if you're obese, that changes if you have diabetes in the family, hypertension in the family, because we know that obesity can contribute to these things. So if you're from a family that's very big and everybody's starting to have hypertension early, then please do a blood pressure. Like see a GP, just do a blood pressure. It's so simple to do. Wrap a cuff around, it inflates. It's not hard.
Not painful. So some of the screening tests that we'd be looking at here in Jamaica, as you say, are the high blood pressure, so the cough.
Right, taking a blood pressure, simply taking a regular.
Yeah. And then checking for diabetes or sugar in your blood, right?
Sugar, right. Mm-hmm.
So those are
urine too. So we do urine dipsticks, and you can pick up sugar in urine. So when you're newly diagnosed diabetic, that's often what they tend to find, that they have the typical symptoms of diabetes, which will remind our listeners, our viewers. Polyphagia, so you get hungry. Polydip, so you get thirsty. So increase hunger, increase thirst, and oddly, you lose weight. So newly diagnosed diabetics tend to actually lose weight, and they spill sugar in the urine.
Right.
So when you dip the urine with a dipstick, which checks for sugar, protein, and sugar, you will find that there's sugar in there. You're not supposed to have sugar in the urine because your body's supposed to break it down, and it's supposed to stay on the inside. It's not supposed to come out in the urine.
It's supposed to go into those muscles and get you moving.
Muscles and be broken down or stored. So when you see that in the urine, that's not a good sign.
Not a good sign.